We are very excited now to have our provider panel share with us some resources and information about supporting people with intellectual and developmental disabilities who are also having mental health concerns. I will introduce our panel facilitator, Dr. Meg Tudor, and then she will introduce the rest of the panel and facilitate the panel and the questions. Dr. Meg Tudor is a licensed psychologist here at the UC Davis Mind Institute, as well as an assistant clinical professor of pediatrics. She earned her Ph.D. from Stony Brook University and completed her postdoctoral training at the Yale Child Study Center. Her specialties include autism assessment and cognitive behavior therapy. She has expertise in anxiety and other symptoms commonly experienced by youth with developmental disabilities.
Thank you, Aubin. Thank you so much. Hello, everyone. Thank you for joining us for our provider panel today. We're very excited to talk to you all about mental health and about well-being. We have 4 amazing specialists in this area who I will introduce in just a moment. Before I do, I just want to make a comment about why we are excited to talk about this, and why it's so important we're talking about this, because mental health and well-being, extremely important topics to overall health, are very often overlooked, especially for individuals with intellectual disabilities, autism, and other neurodevelopmental differences. So diagnostic overshadowing is still very much a thing. And when I say that, I mean that many times when someone has been diagnosed with a neurodevelopmental difference of some kind, after that, mental health doesn't really get thought about that much. Any kind of behavioral presentation or emotion or anything that that person displays gets attributed back to the developmental difference rather than considering, could there be anxiety? Could there be depression? Could they be experiencing other things that are treatable? And if they're treatable, then we could make a lot of change. And then, of course, even for individuals who have mental health needs identified, there are often many barriers to accessing services that are specialized for those individuals and their families. So how fortunate we are to hear from several experts here today about the insights that they have drawn from the work that they do about practical strategies that can be used at home, in school, in the communities, and beyond, to really foster well-being and mental health for these individuals and their families. So the 4 people that we have joining us today are Dr. Tim Barksdale, who is joining us all the way from Philadelphia, Pennsylvania. He is a director of many different clinical services serving children and adults. Thank you for joining us, Dr. Barksdale. We also have Sarah Jacobs, who is a local ABA and problem behavior expert in the greater Sacramento area. Thank you for joining us, Sarah. We also have Sean Inderbitzen, who I hope I am saying that correctly. Did I do well? Great, thank you so much. I practiced. Who is a behavioral health therapist and advocate joining us from Wisconsin. Sean is also autistic himself and may be able to share some personal insights as well as professional insights. Thank you so much for joining us, Sean. And we also have our we know her well, former UC Davis LEND trainee, Danielle Christie, who locally specializes in mental health and specializes in mental health in the educational and school context. Thank you for joining us, Danielle. So now with all of our providers here, let's just start off with talking about kind of what are the foundations of well-being for children and adults with neurodevelopmental disabilities and other mental health needs. Let's just start with foundations. Any thoughts that you all have?
When we're talking about providing support, it's just very important that we look at the entire person. I serve on the National Association of Dual Diagnosis Clinical Certification Committee, and we really advocate for a biopsychosocial approach. So that means that we start off when any concerns are identified is to rule out medical issues, because there are so many medical issues that can play into and look like behavioral concerns or psychiatric concerns. We always rule that out. And then we look at making sure that we do a thorough clinical assessment looking at any type of diagnosis that may exist. And then we try to look at the person's, overall, the way they conduct themselves in terms of looking at a functional behavioral assessment. Are there environmental issues that are playing an issue and being significant in that person's life? Once we look at those things, then we look at therapy. So we're looking at every type of aspect. And when we're talking about therapy, we're not just talking about talk therapy. It could be, looking at EMDR, trauma-focused CBT. All of those therapies can be adapted. And then therapies that doesn't even involve talking, play therapy, recreational therapy, music therapy, pet therapy, any way that we can get to that person's needs. And then, putting it down at last, it's important, but we look at medication. So working with the psychiatrist and making sure that their medication is addressing their proper diagnosis. And through all of that, we want to look at culture and how that affects that person. So again, looking at the entire person.
What types of emotion regulation strategies can individuals or families implement at home? Are there any that stand out to you as providers of things that people watching right now could even try practicing at home today?
This kind of speaks to something that we were discussing earlier, which is mindfulness and the importance of the practice of mindfulness. And one of the things that I really try to work with families and individuals is making sure that we're practicing those coping skills on a daily basis, not just during times of crisis or times of upset, but rather that we are actually, on a daily basis, working on things that allow us to come into the present moment. One of the ones that we do pretty often is real simple, and it's just working on our 5 senses. So when we feel like we're really getting escalated and out of control, okay, let's get back into this present moment. What do you see? What do you smell? What do you hear? Really working through each of those in the moment to bring us back to our present moment. And that's been something that I've used with a variety of different people that's been pretty effective. Yeah,
and can be used across many different ages as well.
Yes.
Adults and 4-year-olds alike can ground with the 5 senses.
Yes. As well as the caregivers, parents, anyone.
Very true. Very true. Sean, were you going to add something to that?
Yeah, I was actually going to bring up a separate strategy, but just exercise. Like with kids with autism, I mean, if you look at Stephen Porges' work, right, he talks about having a lower resting heart rate than, say, your neurotypical population. And so exercise is a really great way to burn cortisol. And so that cortisol builds up, it drives all these anxious, fight, sort of aggressive behaviors. And so finding really fun, competitive games, or even I bet you can't empty this trash can into the garbage before I can, right? Like it's competition based, but it's also like you really, as like whether it's competition based in childhood or where you're working with an adult, and it's more about intense exercise, really like burning that cortisol allows for more mindfulness, which is exactly what Sarah was talking about.
Absolutely. And you bring up a great point. It doesn't have to be, on a treadmill. We can get really creative. We can have a pillow fight, anything that gets kids up and moving, such an important part.
Okay. The question was about emotion regulation, right?
Yes, emotion regulation. Mm-hmm.
Yes, I'd like to offer a resource, skillsystem.org. And that's run by Dr. Julie Brown. She's done an excellent job in adapting dialectical behavioral therapy. And she just puts just simplifies the process. And it has techniques such as clear of mind and on-track thinking and safety planning, getting it right. And it really just kind of translates the basic things that we learn in DBT, such as mindfulness, distress tolerance, and it makes it in a way that everybody can understand.
Awesome. Love to hear that, especially when families are often waiting to be in therapy services, to know that there are a lot of resources available for practicing those same kind of skills at home. So that, just for anyone that might have missed it, that was skillsystem.org by Dr. Julie Brown that Dr. Barksdale recommended. Okay. How about, kind of on the same line of thinking, how about problem solving? Any kind of basics of problem solving that you implement frequently in your own practices that could be used at home or in schools?
I feel like motivational interviewing is a great set of tools for this, specifically ORs, right? So open-ended questions, affirmations, reflections, and summaries. And I bring up ORs because MI really came out of a vein of like addiction treatment, and in addictions treatment, there was really this turn or burn mentality that really didn't work and really didn't get results. I mean, right, and it's still a battle, but we're getting better results now because we use MI. And so it's kind of the same thing, right? Like where it's like we ask open-ended questions, we affirm, we reflect, whether that's a simple or complex reflection. And we summarize, because these things put people in less of a defensive state. Because what happens is what's called the writing reflex, right? Like it's like, and I'm going to use an example for marriage. Like everybody's had that experience with their spouse where it's like, if you just listen to me, and it's like, yeah, if I just listened, like stop shooting me, stop telling me what to do, right? Like, and as soon as we facilitate that dynamic, we've facilitated resistance. And so I think a lot of the interventions, and kids when they're in special education systems have the capacity to get told what to do, right? Like, and they stop being this autonomous individual and they be taught helplessness. And so empowering, evoking, using open-ended questions, affirmations, reflections, and summaries, it's only going to be in your best interest if you want to lessen some of that resistance.
Right, and I'm sure all of us on the panel can relate to starting to see a child in therapy and the parent saying, why do they listen to you when you say it, right? And it's because there's a very different communication pattern that's happening that opens collaboration with the child. That's a great point. Anyone else want to share about problem solving tips?
I'm going to piggyback on Sean and just sort of mention the underlying theme of his, which is talk to the individual. Ask them, what of this situation are they struggling with? Because maybe the part that is a struggle for them is not the part that you may perceive to be the struggle. So we need to talk, we need to ask questions, we need to support and work through. As providers, we need to have a big enough toolbox that if one thing doesn't work or the individual doesn't like it, we can come up with something else and continue to pull from that toolbox until we have something that the individual feels comfortable with and wants to try, and that whoever their circle of support can support them in doing. And so I think definitely everything that Sean said, but I think the key is we need to start with the person that needs it.
Yeah, I would like to kind of string that all together. I think the thing that everybody said that is it has to be a collaborative approach, and together you work to define the problem. Sometimes it's not that clear. Just like Sarah said, what was that question? Defining what is being asked, gather that information, and then generate possible solutions that you could agree to, and then evaluate those ideas and then choose one, and then it may be a reevaluation process. But again, if you're working together, I think that's the most helpful way.
When we talk about generating ideas, sometimes that is 30 different ideas, right? It can be a lot of different ideas. Some of them can be silly. We just want to get a lot of communication going about what the possibilities are. And then once we have a lot of different ideas out there, we can compare and contrast which ones the individual likes better. I think we often see families think of one, maybe just two different ideas of how to handle a particular problem, but make that list as long as possible to keep that conversation going. And like Sarah said, go back to the drawing board whenever you need to some other ideas. So another favorite topic of mine, which is anxiety treatment. So we know that anxiety affects many of the individuals that we're talking about today. Let's just talk about some kinds of tips for either preventing anxiety or helping manage anxiety at home, at school, or in the community.
I would repeat what I already said, which is we have to really practice on a daily basis. You know, whether we call it mindfulness practices or we call them coping strategies, but just this regular deposit into our own self-care. So that when we do bump up against those stressors of life, which are different for all of us, we're coming to them from a calmer place, and we're coming to them with a regulated nervous system, and we're coming to them with some muscle memory on some of those strategies that will help to bring us down when things start to spin out of control.
Yeah, I would add to the, I would add to the self-care, making sure you get enough sleep. Now, I know my colleagues who are on here are probably laughing at me because I average about 4 hours, but you really should get enough sleep so that you can center and refocus. Other strategies include deep breathing. That's not given enough credit. You know, that the act of breathing gives you time to kind of distance yourself from that anxiety, and it helps to clear your thinking. And making sure that you reach out to your support system, you know, knowing that you're not alone, and reaching out for other people to get help, knowing when to ask for help.
What's really important for adults and kids alike, but I think kids need it explicitly taught and modeled, is just having a big toolbox of strategies. One day breathing might work, the next day it might not. And so, you know, just like we do when we're anxious, you know, having a long list of things they can rotate through and try. And for a lot of our kids, making that visual, you know, making it so that they really can remember their tools, or attitudes and actions, we call them, to help. But, you know, just reminding them it's okay if that tool doesn't work. That happens to me too. I have to keep trying.
Yeah, it kind of reminds me of recovery, the Wellness Recovery Action Plan, where you develop a bunch of strategies on how to deal with whatever your mental health issue challenge may be.
I would also just making sure that we're not creating prompt dependency in the use of those coping strategies. That's something that I see too often, is that we're not teaching people how to recognize those internal states and use those as the cues to engage in those coping skills, rather than someone telling you, okay, you should do some deep breathing now. So really doing some of that psychoeducation on recognizing, you know, those internal sensations and allowing that to be your cue to use your strategies.
Yeah, so even something as simple as, rather than, oh no, you look scared, let's do this. How are you feeling? Making it a moment of reflection for the individual themselves. Yeah, and I think anxiety strategies all have some component of independence to them, right? I think I'm hearing that theme as well, that there's some theme of building independence, trying new things. So as you all, anyone that knows me, I talk about exposure therapy all the time, you know, cognitive behavioral therapy, and that means doing things that are difficult. And all of the different strategies that our panelists just talked about are all strategies that are not intended to avoid things that are difficult or avoid any kind of challenge. They're all things to help individuals and families face challenges and become more confident in doing the things that they were once afraid of.
Yeah, mindfulness and distress tolerance, absolutely. Yeah.
Absolutely, absolutely. I could go on about this for an hour, but I'll go to the next question instead, okay? Because that's what I'm supposed to do. So let's talk about the teens and the adults for a moment. So when these individuals are seeking mental health services, they're trying to find a therapist, should they talk about having autism or other neurodevelopmental differences or not? And if they should or shouldn't, kind of tell us why. What's some of your insights on that?
So in the Padlet, there's a tool called Helping Your Therapist Understand your Autism. It's a tool built on the criteria around the ADOS with people who have autism, and they kind of weighed in on its design. But really, yeah, I think disclosing to your therapist is something where you have to be kind of leery, because at least in Wisconsin, of the 55 people I've sampled who are social workers and therapists, 1 in 4 won't treat somebody with autism because they don't feel comfortable. So there's that 25% risk, but I think it's all in how you present it, right? Like if I say I'm autistic versus I say, so I really repeat myself a lot in my head, right? Like that's a much more approachable problem for me as a therapist than say, I just saw the thing in the chat, so I was distracted, but it's much more helpful than saying I have autism, because I, as your therapist, am much more interested in what is the function of the symptoms you're experiencing and how do we get you to where you want to go, versus trying to like cure you.
My automatic go-to is, have the person experienced in identifying their symptoms and what's happening with them. But as Meg pointed out, especially with people with intellectual and developmental disability, that diagnostic overshadowing, they don't even get a chance to get a therapist, because once the person hears your diagnosis, they back off, especially if it's IDD or autism, and I like Sean's approach, identifying what is occurring, because I think that it's idiotic that psychiatric hospitals take this approach, because you think about it. I worked at a psychiatric hospital, and if somebody had severe schizophrenia, they still have that cognitive impairment, but they're going to receive treatment without judgment. But if you put IDD or autism before that, then people are hesitant. So I think that if they get that exposure, as Meg was talking about, with maybe they have to address their own fears in terms of our folks can receive services and are receptive to whatever the approach is, whether it's CBT or, as I mentioned before, EDMR, people can respond.
If we had a panel like this in 10 years, we would have a different story about this, that so many providers now see that, this is an access issue, that all individuals need mental health services. We'll keep working towards that. So speaking of the whole person, and treating everyone as a whole person and from many different angles, let's talk about sexuality and gender and well-being. So if any of you would like to comment on how sexual health is, or how much it is needed to be integrated into individuals' therapy services.
Once again, just give full credit to Nicole Adler, who spoke earlier. She was such a passionate speaker for LGBTQ. I think that's something that definitely needs to be addressed. We like to take away this, I don't know, because we're being overprotective, whatever the case may be, but we, as I started out as a direct support professional, and there's a tendency to be overprotective of the people that you're providing support to. But a lot of times when you're dealing with, especially, well, I guess in any age group, sexuality matters. And if it's denied, it's going to come out in different ways. So it's very important that we make sure that we assess people's knowledge, because maybe they don't, there might be some gaps in their understanding, but that we facilitate dating, intimate relationships, and maybe some of that therapy has to go to the caregivers and the parents so that they can release their anxiety and let people be people.
I loved that, let people be people. And just to add to that, as a provider, we are charged with providing person-centered care, and it should be led by the person and driven by their wants and needs. Regardless of, you know, any provider's individual opinions about it, it's irrelevant. We're here to serve the individual, and if that's what they want or need, then that's what we should be working to support.
Absolutely, and lots of vigorous nodding while both of you spoke on both of those topics from our whole panel. Let's switch gears for a moment to talk about a specific context, which is school. So how about accessing mental health support at school? And that could be for a child who has an IEP or who doesn't have an IEP. How could families ask for this or advocate for this?
I put some resources in the Padlet, just so you all know, but I'm going to kind of briefly talk about ways to access services in schools. And so if you have an IEP, some of you might be familiar with an acronym called ERMS, and that stands for Educationally Related Mental Health Services. So that's a related service that you get an assessment for. And so you can request an assessment, like Dr. Tudor said at the beginning. What happens often, and it's getting better, but diagnostic overshadowing happens a lot in schools too, where a child has autism and then they're placed in maybe an autism program or classroom. And maybe there's a heavy emphasis on communication and language skills or behavior, but sometimes the mental health needs get overlooked. And so it's really important that if, you know, we know the numbers are so high, that that's treated at school. And there's lots of benefits, like Dr. Reven talked about this morning, of having those services provided at school. I think it's just so important too for every provider to know, you know, some of the skills that the child's being taught in these services, especially the teacher who spends most of their time with that child. So ERMS would be a great way to request mental health services at school. One thing I'll kind of emphasize or mention is that anxiety can be tricky to see. It can be, and for reasons we've already talked about this morning, sometimes children it's really hard for them to talk about those internal feelings. So they might not rate themselves high on a rating scale or be able to explain it very well to you, depending on their verbal skills. So I think you want to just make sure that in this ERMS assessment, multiple measures are used to look at for anxiety and or depression or other mental health issues, and multiple informants, you know, that parents are a big part of this, and multiple teachers and different providers at the school, because sometimes they might, you know, not see it, but it's just a matter of not using a fine-tuned enough measure. However, if you don't have an IEP, you can still access mental health services at schools. I put some information in the Padlet for a couple of different ways. Many schools now, especially with COVID, are really concerned about the mental health of all children. And so there's thankfully been some legislation and funding support for more providers at schools. So school counselors, school social workers, and school psychologists are just three of the different types of providers that we're hopefully going to get more of in schools and could provide those services for kids even without an IEP. Schools are a world of acronyms, so I'm going to just say one more acronym. MTSS, Multi-Tier System of Supports, is a way that schools can provide services for kids, and the idea is to intervene before they need an IEP. So they can even provide mental health services through this MTSS system of support, and I put some information about how to request that. A 504 accommodation plan is another way that you could request these services.
How important is it for mental health providers, such as all of us, to have communication with the school when a child is enrolled in school? How important is that line of communication to be open?
I have really mixed emotions about this question because, like, I think it really depends, kind of like everybody said, on the client, right? Like, I think some parents are like, yeah, the school's out to shaft me. And it's like, okay, yeah. So I'm not going to talk to the school. And I don't talk to the school. And like in other cases, they're like, we love this teacher. And it's like, so you're working with that teacher. And so I find it really depends on the individual. Like each family culture is different and each experience. Like I have this one coworker who's like really down on schools because it's run by people who love school, right? Like, so it, you know, like it depends.
I think that's a great point, Sean. And I think, ultimately it's you and your family's decision on what to disclose or share with the school. I think when the school's providing service, though, often there is a disconnect or lack of communication just because of the busyness of the school day and how much, different things like we talked about this morning. Schools have a lot on their plates in terms of educating children. But I think, if families are comfortable, I really think communication is important just for something, for the generalization. So we know research shows that when we teach a child, some skill in our office in this nice one-on-one setting, no distractions, they might be able to show us that skill there, but for them to generalize it or be able to show it in other settings, we have to teach the other people what we taught them, and be using the same language and skills and coping tools. So for that reason, I think, communication can be really helpful for the teacher to just know some key phrases and concepts that might help that kiddo get back on track if they're having an anxious moment. And so parents, also I think Dr. Reven talked a lot this morning about parents being involved, in a lot of the teaching and psychoeducation. And so schools have, definitely different ways of having parent involvement. And I think, again, I think Sean's right. The family should lead how much and how they want that to happen.
Yeah, it's unfortunate. I started as a special education teacher. So if the therapist is involved with the school, then that therapist becomes part of the IEP team and should work together in providing that support. I thought the challenge would be more when the therapist was on the outside. And even then, when you're trained, you're supposed to reach out. And making sure that you're having a collaborative way of getting that information, so that you're looking at, how a person responds and how a child responds in different environments, in the school versus the home, versus in front of the therapist. So it's really important that that information is shared, but you do have to be respectful, as Sean was saying, because different families operate differently.
We have not talked about crisis yet, and we get a lot of questions about when crisis occurs. I think so far we've talked more on the kind of management or prevention side. What do we consider a crisis? When is something truly a mental health crisis? And then we'll move into talking about what we can do or what families can do during those kinds of episodes.
I consider crisis behavior to be behavior that is not only dangerous for the individual themselves, but also those around them, and ultimately leading to a very isolating life, right? Over time, their world and their family's world starts to get smaller and smaller and smaller. What
strategies could we attempt, or could families attempt to de-escalate crisis episodes?
In the moment of a crisis, I think we touched on this already a little bit earlier with some of those grounding strategies of bringing us back into the present moment. But I think there's a lot of groundwork that goes in before we get there. So I'm a marriage and family therapist and a BCBA. So I sort of take this family systems approach paired with applied behavior analysis, because I see them very similarly. They're all about environmental influences and the roles that we play, and sort of what happens when individuals start to get a little bit older and now the roles are shifting, and are we accommodating for the shifting of roles as an individual is getting older. And Lyndon talked earlier about some struggles over guilt that parents might have, and really coming to a place of accepting the individual for who they are. And that can shift a lot, the roles in the home. And I could talk about this all day long, but I'm going to go ahead and be quiet and let someone else have a turn.
Well, I think if a person has a pattern where we have to think about crisis, first of all, I define crisis as when a person is in danger of hurting themselves or others. And, you know, then there's a second tier in terms of when the person neglects taking care of themselves, you know, whether it's eating, bathing, taking care of their basic needs. That all falls into the area of crisis. So when this becomes a threat, I think that it's important that a person have a BCBA, a behavior specialist, or a therapist that is working with them and helping them to develop a safety plan. And in that safety plan, and people get this kind of mixed up. Sometimes they think of it as a safety contract, but I'm not talking about you signing, you know, I will not do this. Now, a safety plan, or what are some of your coping strategies, you know, before this happens? What are the proactive strategies that a person can do? You know, what are the things that you can do to self-soothe? What are your resources? Who can you reach out to? So yeah, just trying to be as proactive as possible to prevent or reduce crisis.
And then also being mindful of the crisis after the crisis, right? Because the crisis after the crisis is usually riddled with insecurity, guilt, shame, embarrassment, fear of, you know, am I going to lose where I'm living? If this individual is living somewhere outside of the home, am I going to get kicked out? Are, you know, my caregivers that I love and respect going to leave me now? Are, you know, there's a crisis after the crisis too, that I think sometimes we forget about.
Yeah, and I think a debriefing process is very important for that. If it escalates to the point of psychiatric hospitalization, you know, having a discharge meeting, trying to reduce that guilt, and identifying, you know, what the plans are moving forward and what strategies can be put in place.
See, and I think you guys have fascinating explanations, but for me, it's much more like, what can we do right now? And so it might sound like, can you slow down your pace a little bit, right? And just asking some really intentional questions to actually like get them to be mindful, or like taking, like, say their body wants to dance, like allowing them to dance. As weird as that seems, like in my present, for them to just be like, woo, like, right? But like they're getting their body moving, they're getting endorphins flowing, like, and then something like the CAMs or safety planning for me really comes into play with these clients, because it's about like what are they going to do in this moment? And then in this moment, if we can get to a lower place, usually like when crisis planning happens in a session, it's like whatever appointment's next goes out the window. So like, but really, like, what does it take to calm in that moment, right? Like, because it's a present crisis just as much as it is a future one.
Well, I think that's a matter of when you catch it. You know, if you're aware of the person's warning signs and you see that they're about to escalate, all the things that you identified, Sean, are absolutely going to be helpful. When a person gets in that crisis zone, communication cuts down, and you have to really, you know, deal with the danger that's involved. You know, is somebody getting hurt? Is a parent getting hurt? Is someone hurting themselves? You know, so the ability to communicate does reduce.
And also making sure that we're teaching the self-regulation to the people around that individual, because if we lose, you know, our own ability to control ourselves, there's no way that we're going to be able to help other people.
Right.
Let's talk a little bit about being social, right? So we get a lot of questions from parents, you know, that I think there's kind of a confusion between being social is good, and it's part of our mental health and well-being. We all learned this during COVID, right, when things changed a lot. But we also want to be person-centered, and we want to work with individuals on their own personal goals. So how important is that social interaction piece, especially if we're working with individuals who say they're not really interested in that?
So I'm going to go back to the person-centered, and what does being social mean to you? And how do you feel fulfilled in that social realm? Is it through groups of people? Is it more one-on-one conversation? Is it better over the phone versus in person? How do you want to engage socially, and what are you currently comfortable with engaging in socially? And then if what you want is not what's currently happening, then how can we start to take steps to move in that direction? And a lot of that often comes back to anxiety again. And how can we radically accept that I can still engage in social interactions even while I'm having sweaty palms and tightness in my chest? I'll often say we can be both scared and brave at the same time.
I love that idea, Sarah, of, it's not like, hey, let's go to your cousin's birthday party. The child says no, the end of the social discussion, right? It's more, what does that child actually have an interest in doing? And how can we start there and work our way up? Kind of along the same lines or similar lines, through a lot of the discussion we've had today, we've been talking about self-soothing and about, we just talked about planning for things that a child would help de-escalate a child if they were upset. And I think a lot of the topics that have come up relate back to just things that children or adults enjoy doing, like their special interests, what they enjoy. Can any of you just comment on how much that is integrated into the practice that you do and the therapy that you provide?
For me, at least, that can be a really great strategy for people to avoid their feelings, which I don't think is super helpful. Like, I had a client the other day with autism tell me about Carl Jung and the shadow self, and it was great, but he was avoiding grieving about his dog, right? And like feeling the only way through grief is through it. There's no bridge over it. There's no pathway around it. And so I think the repetitive interest can be a really good port of entry if you're trying to build rapport. But if you're trying to treat, say, anxiety or grief, right, then it can kind of be a barrier too.
I find that it's, like you said, it's kind of it helps you get in the door. And so for me, I will I definitely in the beginning, to build rapport, I want to know all about the kiddo's interests. And then I do some research, and I've learned more about Roblox and, obscure interests than I ever thought I would. But even after a long time of rapport, I let the kiddo talk about that either at the beginning or end of every session, whatever their thing is. And so I think, maybe it's different for children, but it's so important for them. And I really think typically developing kids too, we all like to talk about what we're into. So for me, it's been really critical. And like Dr. Reven shared this morning, that's the main adaptation that I use. But like I said, I do that with all kids because I think they all just want to share about their interests.
Because I work in crisis, and because that ultimately causes worlds to get smaller and smaller, I think this is really important. And so a lot of times I'll work, most of the individuals I work with are adults. And so I'll work with them and whoever is supporting them to say, okay, well, you want to be able to go to the water park. Great. What's the barrier that's causing us to not be able to go to the water park right now? okay, well, what can we do to mitigate those risks? How can we use, getting more support, more people perhaps? How can we use some role play? How can we use some of the desensitization work that you've talked about of, these micro exposures or micro shaping to be able to get there? Maybe we can't get there tomorrow, but we can set it as a goal and start taking steps in that direction. But I think it's really important because the individuals that I work with, their worlds get so small. They just stay home all the time and they don't go anywhere. And nobody wants to live like that most of the time. I mean, I know there are some people that want to live that way, and more power to you, but a lot of the time that is not how we want to live.
Definitely. Great points on all of that. And we have talked about so many different topics, and we have gotten questions about the various topics that we have discussed so far. So we're going to go ahead and do some question and answers from the audience now. So again, whichever panelists are interested in sharing their insights about it. So I think this question came to my mind while we were talking as well, when we were talking about crisis. A lot of people don't feel comfortable or safe calling 911 in a crisis. And when that is the case, what do you recommend? Are there alternatives to that?
There are services. Obviously, it depends on where you live and funding and all of that. But at least in the area that I live, there's a few different providers that do provide like an on-call type service where there's perhaps a crisis, an active crisis occurring, and they can call a provider that will come to their home to assist. So I think it just depends on where you live and how the funding works in your area. But I agree. I have responded to crisis situations where things have continued to escalate, and 911 has had to be called, and it really depends on who's responding on how well that situation will go.
Yeah, it definitely depends on the region that you're in. I know at Marikey, we have the dual diagnosis treatment team who actively works with the team so that they can avoid those type of things. It also goes back to your planning, so if you're hesitant in calling 911, then you have to come up with a backup plan of what you're going to do instead.
Definitely. And I think this question, it points out to me, and hopefully a lot of people on the call, how we can also become advocates, and, where we need to continue to push for more mental health related care in various systems that are not working right now, and what kind of leverage we can have in continuing to change some of these bigger picture systems that we're talking about. Okay, let's think about back to parents. We brought up parents and families a lot today. What about resources for parents, and what about practical tips for parents when they're in these stages that can be very long-term for some of the individuals we're talking about of high stress?
I feel like parents have a really unique experience, and it's almost like a grieving process that happens over and over and over again, right? And so like there's a book called Buried Underneath the Years of Dust, and it promotes this non-evidence-based practice in autism called tapping, or I forget what it's called, but essentially the book does a really good job though of capturing this attorney's experience of like, wow, I've really lost my kid's ability to go to preschool, my kid's ability to go to college, graduation, prom, right? Like these are miniature deaths all throughout parents' life, and having a therapist to cope with your own losses, I think, is super important because it is a loss.
I talk a lot about, and I'm sure we've all heard this analogy, but just like in an airplane, putting on your own mask before you can get your kids on. And so I think Sean's absolutely right. And I think As a parent myself of a kiddo on the spectrum, I feel this quite a bit. And, you know, you just like you're teaching the kids to use coping tools, not only in times of distress, but to carve out that time every day. It's the self-care for parents and how they can do that. I also think, you know, a big thing is just, you know, making sure that, especially in the early stages of diagnosis, there's so many unknowns and we cannot make any predictions or estimations of what a child will or won't do. So to try and stay away from that. And if you have professionals or doctors that are making glass ball predictions, to find someone else, because especially now with it's, I think, getting better and better with services and access. I think there's less limitations and bars that we should not be setting.
I think also acknowledging, especially in the area of crisis work, acknowledging the trauma that can be experienced by the parents and the caregivers. Sometimes I will, you know, draw from my training in domestic violence and reminding them that, you know, especially, again, I'm talking about crisis behaviors, repeatedly over time, parents struggling with their own safety in their home. And so, you know, we try to be really mindful when we go in, when I'm wearing my BCBA hat on, to not be like, oh, okay, here's what we're going to do. Here's a behavior plan. But instead recognizing they sometimes have their own work that they need to do before they can even adhere to a behavior plan. You know, we're saying, oh, say this, do this, but they're having their own physical reaction to what's going on in the room that is overshadowing their ability to implement that behavior plan. And we need to pay attention to that. And yes, sometimes that is work around grief. Almost always that's work around grief. And then also learning to engage in those coping skills so that, you know, when we have chronic stress, our ability to be able to function is altered. And so we need to be able to calm and soothe our nervous systems. And that means engaging in daily practice that we may not want to do. And I also want to acknowledge that parents that are caring for individuals with crisis may not have any support or respite or anybody to be able to be with their individuals so that they can go take a yoga class or they can go to therapy. And so how can we bring those things to them? And so I think as practitioners, we need to be careful about not saying like, oh, well, you know, do X, Y, and Z. It's all about self-care, but recognizing maybe they can't go do those things. And so how can we bring those things to them?
Absolutely. Meeting the family where they're at, you know, even if that's 2 minutes in your bedroom alone in a day. That has definitely been a goal for some of the parents I've worked with. And that 2 minutes is meaningful practice every day, whatever we can work with to get the parent support. And I think you all brought up really important topics of, you know, that parents as individuals are also part of the process. You know, they really are. And speaking of parents, speaking of the whole family, we had a question close to my heart, which is that of siblings and supporting siblings and how they can be part of treatments or if they may need to access their own individual mental health services. Would anyone like to share some thoughts on that? Because I could. Okay, okay, I'll go ahead. So first of all, I'm just so glad that question came through. You know, we're talking about mental health being overlooked in the field of autism and neurodevelopmental disabilities. Siblings get overlooked all the time as well, you know, in the family system and research and services. That's one of the reasons I'm very interested in working in that area. So right now, it would be difficult to find, you know, to go out and find a psychologist or a therapist that has a specialty specifically in that area. Like they see siblings and they treat siblings for their sibling needs. Very lucky if you can find someone like that in your area. But otherwise, really we're thinking about, like a lot of the things we've talked about today, it's not about a label per se, it's about what are the problems that are coming up and what kind of therapists could focus on that. So if your other children, the siblings, are at higher risk for anxiety, you're going to want to find an anxiety specialist. If it's ongoing sibling conflict and family conflict, you're going to want to find a great family therapist in your area, right? So you're not limited to that autism specialty per se. We really want to be looking for what are the target goals for the children and how we can work on them. There's also a lot of great books, and maybe this is something we could add to the Padlet since this question came up. There's a lot of great books and workbooks for children and families, for siblings, for younger siblings and teen siblings to work on together, because it's really about what the research has showed is, again, a recurring theme today is open communication, an open family understanding. Wow, communication again, right? Open communication about different sibling needs. Why does my brother get more time, with mom than I do? Really dedicating special time to the sibling, finding ways to have a special relationship with that other child. Again, can be difficult in the big picture, but those are all things that we find are really helpful for promoting their overall well-being. And then in addition to finding therapy services that may address their target goals, whatever they might be for the sibling. Okay.
Yeah, and
again,
I'd like to offer, I'm sorry, go ahead, you want to finish your thought?
No, I was just going to say I could talk about it. I was going to say, again, I could talk about this all day, so I'll stop myself. So you take over, Tim.
No, I just wanted to offer hope. I mean, when I was 3 years old, my brother was born with significant cerebral palsy, and that included communication issues. So I think as a result of him, pretty much all of our family got involved in these services, and probably my ability to communicate and to be a good therapist and just all the skills that I have, started out with him and his peers and dealing with the schools and the systems. So I credit him for the career I have, because I think, he taught me a lot.
That's amazing, Tim. Thank you for sharing that.
I was going to share just a local resource. My daughter went through the sibling support group at the Mind Institute that was virtual and loved it. I think that regional centers have something called SIB shops, so you can look for something like that. But I love this topic too. It's so important.
Yeah, definitely. Just being around, just like parents benefit a lot from being around other parents in similar situations, giving your sibling children the opportunity to be around other siblings and talk about their unique life experiences that may not feel relatable to others can be very, very beneficial. I cannot believe it. We have 2 minutes left already with all the things that we've talked about. Let's do one last question from the audience, which is, I think this is another system-wide type of thing, but how can we keep demystifying, autism and neurodevelopmental differences for other providers, right? So we're a unique group, I think, today on this panel that are comfortable and excited to treat mental health issues that come up in these populations. A lot of other providers, as Sean mentioned earlier, are not. How can we continue, in our communities and in the fields that we work in to keep encouraging and training these other providers to get on board?
I most definitely have an opinion on this, especially because Wisconsin just doesn't get it, right? We still have 2 systems, one for mental health, one for developmental delays. Make them one system, reimburse them under Medicaid. They are treatable conditions and they change with time. The other thing is, there's only 5 MSW programs in the country that offer developmental delay courses. So more graduate programs in mental health need to start offering courses on autism, developmental delays, because these things are diagnosable. I mean, I'd like to see it go as far as genetic disorders, but I'm just rooting for developmental delays at this point.
Hey, I have to piggyback on what Sean said. I've actually did my dissertation and found evidence based on exactly what he said. We asked clinicians, do you provide services to this population? Why don't you provide services to this population? And the answers came out with lack of exposure. They were not, I went through a doctoral program in psychology, and I can remember one class, and they showed a black and white film on behavior modification. That was my only training. So, and then when I went into my internship, whenever somebody with IDD or autism came in, they would say, "Where's that intern? He knows about this. We don't." So, so the education in the colleges need to happen, and they need to do internships and practicums in homes, in residence, in family homes, so that they have an understanding on how to support this population.
And I'm going to say it also falls back on us, right? So I'm part of 2 organizations because of the 2 credentials or license that I hold. So, if I go to Calaba, everyone's pretty familiar with the populations that we serve in ABA. And then if I go to the California Association of Marriage and Family Therapists conferences, they're very comfortable under their umbrella. But when I go to those conferences, I have a responsibility to begin to discuss the other side of what I do with the other group of professionals, and being able to, when I'm at an MFT conference, educating the other providers and demystifying the population and the services. And on the other side as well, I think as clinicians, we have a code of ethics, and we have to stay within our scope of competence, and we have to stay within our training. And so we're always, very afraid of going outside of that and being labeled as being unethical. But those of us that have started to really blend the 2, we have a responsibility to go and educate on both sides of the aisle.
Definitely, and that's why we at Mind are trying to do a lot of training in this area and invite a lot of people to learn about this that haven't otherwise, because I definitely hear that as well, the scope of competence and ethics. And then I always think, well, how about ethically turning away people that are in need of services, right? So we've got a lot of work to do in that area.
There's this one mom, and she says something to the effect of like, would somebody just help? Right? Like,
yeah.
And I think that grossly outweighs like whether or not I feel confident or not. Because like, if I'm going to ask my clients to be brave, like I have to be brave too, right? Like it's one thing to try and like modify someone's eating plan, right? Like, and pretend to be a dietitian versus doing a therapy I'm a little less familiar with. And like,
Or doing therapy you're very familiar with, but just with a child you haven't met before. It's doable. It is doable, and definitely a movement that needs to keep being made. Okay, this is it. We got to end at some point, so I'm going to call it now. This has been our provider panel. Thank you so much, Tim, Sean, Danielle, and Sarah, for joining us today and sharing all of your expertise. It was wonderful having you and getting to talk with all of you.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.